Hello friends, today's topic is brain death management. So brainstem consists of midbrain, pons and medulla. It contains nuclei of the last trained cranial nerves and ascending and descending tracts. The reticular formation is complex network of nuclei and the interconnecting fibers. Reticular activating system, that is a RAS system, which occupies the core of the brainstem, provides anatomical and physiological basis for wakeful consciousness. So we'll discuss the parts of the brainstem with associated function and the effect of lesion. So core of brainstem, that is reticular formation and reticular activating system, is responsible for consciousness. And if any lesion occurs in this area, then that results into the coma. The respiratory centers are situated into the pons and medulla. They are responsible for drive, and the lesion in this part results into apnea and the loss of spontaneous breathing. The cardiac and the vasomotor centers are situated into the medulla. The function of it is to maintain blood pressure and the heart rate. And any lesion in this area results into the fluctuating blood pressure and the heart rate. All motors and sensory pathways are situated into the brainstem except in the vision and the smell. It mediates motor and sensory impulse, and any lesion results into the bilateral paralysis and complete anesthesia. Now, the cranial nerve nuclei, it mediates cranial nerve functions and reflex. And if any lesion occurs, then it results into bilateral loss of cranial nerve function and reflexes. As brainstem is structurally and functionally very compact, and even small lesion can destroy the vital cardiac and respiratory centers, disconnect cerebral cortex from brainstem, damage the sensory fibers from higher center of consciousness, perception, and cognition. Damage to reticular formation may lead to loss of cognition, persistent unconsciousness, and coma. Role of cerebral cortex in consciousness. Consciousness is the wakeful and awareness of oneself and surroundings, for which normal functioning of the reticular formation and cerebral cortex is necessary. Hence, consciousness is altered in the lesion of cortex and reticular formation. To assess the function of entire brain, diagnostic test of cerebral cortex function and the brainstem function are done. Cerebral cortical function can be assessed by testing for electrical activity with EEG, and absence of cerebral cortical function can also be determined by lack of verbal response and lack of spontaneous coordinated eye movements. Absence of cerebral circulation is also indicative of cortical death. Causes and pathophysiology of brainstem death. Direct traumatic injury to the head, for example, if happens in road traffic accident or any subarachnoid hemorrhage, ischemic stroke are the most common causes of brain death. Others include intracerebral hemorrhage, hypoxic ischemic encephalopathy. These causes cause severe damage to the neuronal tissue, leading to edema and increase in ICP. Now, this elevated intracranial pressure reduces cerebral perfusion pressure and cerebral blood flow. A vicious cycle is established in which decreasing cerebral perfusion and increasing ICP reinforce one another until blood no longer enters the cranial cavity. It results into transtentorial herniation and coning at foramen magnum. This herniation crushes the brainstem. At this point, brain, including the brainstem, is rendered permanently dysfunctional. Late neuronal injury can be explained by reperfusion mechanism associated with hypoxic ischemic brain injury. Now, the diagnosis of the brainstem death in India. Brainstem death is medically and legally defined as totally and irreversible cessation of all brainstem function. In India, THO Act 1994 and the THO rules 1995 are only the laws where brainstem certification procedures have been laid down. Form 8 of THO Act and the rules prescribed into the brain death certification format is to be utilized to certify brainstem death. It states who should diagnose. Team of 4 medical experts, including medical administrator in charge of hospital, authorized specialist, authorized neurologist, neurosurgeon, medical officer treating the patient. These 4 people can diagnose the brainstem death. Now, the criteria for diagnosis of brainstem death in India. Patient should be deeply comatose due to irreversible brain damage of the known etiology. Exclude reversible cause of coma. Patient should be on ventilator because of cessation of the spontaneous respiration, and exclude the neuromuscular blocking agent as a cause of respiratory failure. Now, the test of brainstem function. Function of the brainstem is determined by the presence or absence of spontaneous respiration. By testing the cranial nerve, whose nuclei are situated into the brainstem. Now, what are these cranial nerves? And we'll see one by one which tests are necessary for brainstem function. So the first one is pupillary light reflex. It is for testing cranial nerve 2, second and third, and it is situated into the midbrain. Now the second reflex is vestibulo-ocular reflex or caloric test. It is for the cranial nerve 3, 6, and 8. It is situated into midbrain and pons. And the next is oculocephalic reflex, commonly known as Doll's eye phenomenon. It is for cranial nerve 3rd, 6th, and 8th, situated in midbrain and pons. The next reflex is corneal reflex. It is for 5th and 7th nerve, situated in pons. The next reflex is pharyngeal reflex for cranial nerve 9 and 10, situated into medulla. Then comes cuff reflex for cranial nerve 10, situated in medulla. Then the next is vagus nerve function for cranial nerve 10, situated in medulla. Then response for painful stimulation, cranial nerve 5th and 7, situated in medulla. Then the next is apnea test for respiratory centers, which is located in pons and medulla. Now, what is the difference between the brainstem death and the persistent vegetative state? So the persistent vegetative state, there will be damage to cerebral cortex and brainstem will be intact in this. Patient will be awake with the cycles of eye opening and closing, but unaware spontaneous respiration continues. Circulation will be stable, not in need of life-sustaining treatment, requires nutrition and hydration only. Cranial nerve reflexes will be preserved. Recovery may occur, but it's very rare. Now, what happens in brainstem? Brainstem, there will be the lesion into the brainstem, which causes the damage to the ascending reticular activating system, results in deep coma. Damage to respiratory centers results into the loss of spontaneous breathing. Then there will be the fluctuating blood pressure. Patient will be needing life-sustaining treatment, ventilator and pressor drugs, loss of cranial nerve function and reflexes, irreversible and incompatible with the life. मी थोडा वेळ घेतो, 5 मिनिट. स्टार्ट करू. All brainstem reflexes should be absent. Pupillary right reflex, that is, pupils are dilated, fixed, and do not react to light. Doll's head eye movement, that is, oculocephalic reflex, will be absent. That is the absence of conjugate deviation of eyes when the head is fully rotated to one side. It should be performed only when there is a no fracture or instability of the cervical spine. Then there will be the absence of corneal reflex. No motor response to the stimulation within any cranial nerve distribution. No response to supraorbital pressure. Then gag reflex, that is pharyngeal reflex, will be absent. No cuff reflex and no vestibulo-ocular reflex. That is when there won't be any eye movement after installation of 50 ml of ice cold water into each external auditory meatus for 1 minute. Then next comes apnea test. There will be absence of respiratory movements after disconnection from ventilator for sufficient amount of time to have a PCO2 rise above threshold, that is more than 50 to 60 minutes for stimulating respiration. Apnea test must be demonstrated as a part of any brain death declaration. Now, what is the prerequisite for apnea test? We should must ensure that certain prerequisites are satisfied before performing apnea test. That is core body temperature of 36 degrees Celsius. Blood pH should be normal. Systolic blood pressure should be at least 100 mmHg. Then euvolemia and eucapnia are recommended. There taste should be absence of there should be absence of hypoxia and prior CO2 retention. Apnea test should not be performed when subject is under influence of paralyzing drugs, that is pancurone. Apnea test procedure. We should pre-oxygenate with 100% oxygen for 10 minutes to PCPO2 of more than 200 mg. Then disconnect the patient from ventilator. Place catheter through endotracheal tube close to the level of carina and deliver 100% O2 at 6 liters per minute. Then we should look for closely for respiratory movement at least for 8 to 10 minutes. Respiration is defined as abdominal and chest excursion. The patient with the intact brainstem can be expected to breathe within the first few minutes as hypercapnia develop at the rate of 3 mmHg per minute. About the test, if blood pressure falls down to below 90 mmHg, or if oxygen saturation falls to less than 85% for more than 30 seconds, if no respiratory drive is observed, then repeat the blood gas analysis after approximately 8 minutes. If respiratory movements are absent and arterial PO2 is 60 mmHg or more, or at least there is a rise in baseline PCO2 of 20 mmHg, then apnea test result is positive and it supports the clinical diagnosis of brain death. If the test is inconclusive, but the patient is hemodynamically stable during the procedure, it may be repeated for longer period. Now, what are the contraindications for apnea test? Arterial hypotension, that is systolic blood pressure less than 90 mmHg, hypoxemia, that is PaO2 less than 60 mmHg, severe acidosis, that is pH less than 7.2. Now, what are the complications? Hypotension, acidosis, hypoxemia were reported during apnea test in more than 2/3 of the patient in study. Major complication includes pneumothorax, cardiac arrhythmia, myocardial infarction, barotrauma have also been reported during the test. Ancillary test. Confirmatory tests are the option in most guidelines and the result where clinical diagnosis of the brain death, including apnea test, cannot be completed or is doubtful. Cerebral angiography, particularly four-vessel angiogram demonstrating absent cerebral circulation, remains the gold standard supplementary test for brain death. Then CT angiography, CT perfusion, and magnetic resonance angiography, though mentioned in some of the guidelines, have not been validated or recommended. EEG continues to be the most common applied supplementary test for brain death. EEG is significantly affected by hypothermia, drug administration, metabolic disturbances, and diminishing its clinical utility. Transcranial Doppler is non-invasive technique and was found to be highly sensitive in determining absent cerebral perfusion. Radionuclide imaging like technetium 99M scan has been widely performed. There is no uptake of isotope in the brain parenchyma, hollow the skull phenomenon in brain death. The use of multimodal evoked potential in diagnosis of brain death was described. A combination of median nerve somatosensory, brain stem auditory, and visual evoked potential was used in the evaluation of the brain death. EEG had the highest completion rate, sensitivity, and specificity. Transcranial Doppler followed the completion rate, but poor sensitivity and specificity. The somatosensory evoked potential had the lowest completion rate, good sensitivity, and poor specificity. After the combination of ACP or TCD with EEG, specificity can increase to 100%. Thank you.